my name is Roy van Wanrooij. I'm a gastroenterologist at the Amsterdam University Medical Center. I would like to thank Endoscopy for the opportunity to talk about our paper that is titled EUS-guided gastroenterostomy versus duodenal stenting for malignant gastric outlet obstruction, an international multicenter propensity score match comparison, which was a collaboration between our center and the university hospitals in Leuven and Milan. The paper discusses malignant gastric outlet obstruction, which was, until recently, treated either with surgical gastroenterostomy, considered the gold standard, or alternatively for patients unfit for surgery or those with a prognosis shorter than 3 months, endoscopic enteral stenting. EUS-guided gastroenterostomy is a relatively new technique that seems well suited for these patients, since in theory it combines the best characteristics of both techniques. It induces a rapid clinical response without significant comorbidity, while long-term stent patency seems to remain high. Indeed, we and others have showed that in comparison to surgical gastroenterostomy, EUS-guided gastroenterostomy has a similar high technical and clinical success rate, while it is associated with a lower rate of adverse events, shorter time to oral intake, and a shorter hospital stay. Data comparing EUS-guided gastroenterostomy to duodenal stenting is however still sparse, and this while duodenal stenting is still being used in the majority of patients with malignant outlet obstruction, which may be attributed to both patients' and doctors' preferences in combination with the notoriously difficult task to predict patient survival. Thus, we set out to compare EUS-guided gastroenterostomy to duodenal stenting in patients with malignant gastric outlet obstruction. In the 3 participating centers, we collected a total of 214 patients, equally divided between both groups. We attempted to eliminate bias between both groups by performing a propensity score matched analysis. We matched on age, gender, etiology, disease stage, presence of ascites, and peritoneal carcinomatosis. After matching, 88 patients were allocated to each group. We chose 2 primary endpoints, namely clinical success and stent dysfunction. Clinical success rates were significantly higher in the US group compared to duodenal stenting, with 91% versus 75%. The reason for the higher clinical success in the US-guided technique may be the shorter stent length, which likely facilitates food passage into the small intestine better than the longer duodenal stent. Also, the tumor may compress the duodenal stent, which therefore may be unable to expand to its full diameter. This while in US-guided gastroenterostomy, the stent is placed away from the tumor and always fully expands. Noteworthy, in our study, almost all patients received a 20 mm stent, which is superior to the smaller 15 mm stent, as we and recently Bejani and colleagues have reported. The second primary endpoint was stent dysfunction, which occurred more frequently in the duodenal stenting group. Results from our study are in line with previous studies, showing that stent dysfunction is indeed a common problem in duodenal stenting, since tumor progression leads to stent occlusion, while stent dysfunction doesn't seem to be a substantial problem in US-guided gastroenterostomy. One of the worries is that US-guided gastroenterostomy is a more invasive procedure than duodenal stenting and may lead to more severe adverse events. Yet our study shows that in hands of endoscopists that have received adequate training in expert high-volume settings, US-guided gastroenterostomy is a safe procedure. So in conclusion, our international multi-center propensity score match analysis showed that US-guided gastroenterostomy had a higher clinical success and a lower rate of stent dysfunction, and thus suggests that US-guided gastroenterostomy may be preferred over duodenal stenting. Until high-quality data, such as randomized controlled trials, show otherwise, we now utilize duodenal stenting only when US-guided gastroenterostomy is technically impossible, for instance when the jejunum cannot be visualized from the stomach, or when large amount of ascites are present. For more details, I would like to invite you to read our full paper in Endoscopy, and I would like to thank you for your attention.